Dr. Weinstock received his medical degree from the University of Rochester and completed his residency in internal medicine at Rochester General Hospital in Rochester, New York. He completed a gastroenterology fellowship at Washington University here in St. Louis. Dr. Weinstock is board certified in internal medicine and gastroenterology. He is an investigator with the Clinical Research Center and Sundance Clinical Research. He is currently the managing partner of Specialists in Gastroenterology and the president of the Advanced Endoscopy Center. We are grateful that Dr. Weinstock has recently taken an interest in treating POTS, mast cell activation in EDS patients. Please join me in welcoming Dr. Leonard Weinstock.
Thank you, Brad. I'd like to thank 42 patients with POTS who have come to see me and made me a lot smarter because up until 2 years ago, I didn't know about POTS. I didn't know about mast cell disease, and I knew about Ehlers-Danlos, but it's only come to the forefront in GI in the recent couple of years. Now, for those who are suffering from various syndromes, will you raise your hand if you experience this joke right here? Rodney Dangerfield? A lot of people. Okay, and that's the problem with doctors. If they don't understand anything, they blame the patient, and that's quite unfortunate. And my 30 years of practice, I subspecialized in irritable bowel syndrome, and I've always been cognizant of this issue and have tried everything out there new to help patients, because syndromes mean the doctors are not sure what's going on. The word idiopathic, unknown cause, is something that I just never knew about in med school until I got out into practice. There were syndromes. It's not just hypertension and diseases that Dr. Quattromani can look at by an echo and so forth. Syndromes are conditions where we have a set of symptoms that define a condition, and yet we don't know the exact cause. But, and so patients with POTS, mast cells, and EDS, Ehlers-Danlos, suffer from going years without a cohesive diagnosis. And I've certainly made errors up until 2 years ago on many patients, it turns out. And these are patients, which I'll go over in a second, who present with weird symptoms. And they have seen different doctors. They go see a rheumatologist who push on their muscles and they're tender, and they say, you've got fibromyalgia. But then they say to themselves, it's really not a disease, it doesn't exist. And I've seen plenty of people who cannot poop because they can't relax the anal sphincter, and it doesn't make sense to me, but a number of these patients are POTS patients. In fact, one of mine went for colectomy and has a colostomy because she could not evacuate. And only now do I say, oh my Lord, that patient had POTS. And so that's one of those things that we just have to learn, that not one doctor can put it all together unless they're really cognizant of it. This woman taught me everything I know. She contacted me. She lives in Alaska. She's been ill for 25 years. It took 19 doctors to figure her condition out. I didn't diagnose her, but I helped her. She started at age 18 with typical mast cell symptoms. She'd go through Macy's, and with scents, she'd get flushing, rash, and nausea. At 20, she started getting GI symptoms, bloating after eating, chronic constipation, and a rotten egg smell to her gas. Then she had POTS symptoms, which you can all recognize. And then ultimately, she became disabled from her job as a statistician, and she had 45 different symptoms. The worst was, of course, passing out. She had problems with evacuation, so if she sat on the toilet and strained, she'd pass out. She'd go into a big box store, pass out. Her stomach shut down, she could only have liquids, and she couldn't tolerate things. And when she sat down, laid down, she would have pain in the legs. To dependent edema and dependent urticaria, pressure-induced urticaria. Try to remember those words because they're important later on. She went to Mayo Clinic and they diagnosed her, but they treated her and could not get her better despite 12 different drugs, support stockings, et cetera, et cetera. So, you know, if this patient came to me, as others probably came to me over the last 28 years, not including the last 2, I'd say, oh, they've got nausea for some reason, constipation, and so forth, and weird symptoms. But now I'm learning and I'm trying to teach my partners and getting grand rounds at Washington U. If you've got really all these widespread symptoms, think out of the box and think about POTS and mast cell disease. And here's an example of the patient I took care of for 17 years. She stuck with me for a long time, since she was 17 actually, and she had 250 trips to the emergency room, numerous admissions for abdominal pain and diarrhea. She never looked terribly ill, but she had terrible symptoms. And then she had upper abdominal pain, she had her gallbladder removed, they thought she had scar tissue at the end of the gallbladder, end of the bile duct, and did sphincterotomies, incisions to open up the bile duct, and actually had 9 different ones. I didn't know what was going on with her, so I actually sent her to 4 different universities to try to get a diagnosis, and everybody came back with a big fat 0. She went to another university on her own for tachycardia and passing out, and she got a tilt table, was diagnosed with POTS, and then she came back to St. Louis to live, and every time she got tachycardia, she went to Mercy Hospital. Every time she had GI symptoms, she went to Mobile. And I never put the 2 together because she never complained about it to me, and then I started treating her with something new and unique based on the patient from Alaska that I showed you. And she's been doing great. So GI symptoms, the top 3 are highlighted. Acid reflux, difficulty swallowing, POTS. We'll talk about gastric emptying and the problems in the upper part, and then down lower, the sphincter dysfunction. But there's also intestinal disease in between based on autonomic neuropathy. So the top 50% of patients with POTS are listed here. And you can see GI is not on it, but it comes in pretty quickly. However, Dr. Ahrens at Scripps, who's a cardiologist, said in his diagnosis of more than 500 patients that GI symptoms are prevalent, and the top 3 are listed here: headache, fatigue, and GI symptoms. Now, what hasn't been mentioned, there are defined causes for POTS, and those include Lyme disease, Gardasil, HPV vaccination, Lyme disease, various infections, trauma to the head and nervous system. But these are contributing factors that I've listed. Most of the patients are idiopathic. We don't know what triggered it off, except that we're learning a lot more about the autoimmune antibodies playing a big role, and I think Brad's going to address some of that. So autoimmune diseases such as celiac disease does play a role, Hashimoto's, thyroid disease, but you can see more than 33% have mast cell. And I will say that Dr. Kem in Oklahoma, who's an endocrinologist that works out of a lab that deals with cardiac disease and autoimmune antibodies, feels that virtually every POTS patient has mast cell disease, and that's why they have POTS. But that's perhaps a stretch. Goodman, who works out of Mayo, Arizona, feels that it's extremely common. It plays a role, and he treats, and doesn't even test for it, but he treats mast cell symptoms in everybody with that. Okay, so a Mayo Clinic study early on, looking at a 20-year period since 1995, looked at 163 patients. Nausea, bloating, diarrhea was common, abdominal pain, constipation. Gastric emptying problems, so you put food in your stomach, you do a motility test to see whether it's slow, which you kind of expect if you were shutting down the vagus nerve by sympathetic overdrive. But what's weird is that many of the patients had rapid gastric emptying. So with rapid gastric emptying, all that food's gonna get out of your stomach, and then it's not gonna be processed, so you'll have digestive problems. And that may feed into bacterial overgrowth, which I'm going to go over in a second. In another study looking at the small intestine, they found that constipation, delayed outlet or movement through the colon was very common, and then 80% couldn't relax their anal sphincters. So 1 + 1 equals difficulty passing bowel movements. It's said when you read about POTS that irritable bowel syndrome is very common, and that's a wastebasket term, which we really should end now, because IBS actually has pathophysiology that is rooted in the condition of POTS and mast cell disease. And I'm going to explore SIBO, small intestinal bacterial overgrowth, and mast cells in this lecture. So here's this little study, again, the same study out of Stanford, and they found that over half the patients had slow moving small bowel, as evidenced by dilated loops of bowel. So that makes sense. You go to sympathetic overdrive, you don't have the parasympathetics causing peristalsis. Peristalsis is what moves food from one end to the other, and if you don't have it, it just sits there. You can get bacteria feasting on the carbohydrates, then you get bacterial overgrowth. So that's a risk there. A touch on EDS. There's a nice handout that you've got. Here's actually a patient of mine from Florida who was a yoga teacher, and you can see how flexible she is. And a very cool study, Brad might be reviewing this, but nonetheless, it was a big study. Over 3,300 patients were looked at to see if EDS was playing a role in their POTS. And EDS by physical exam and history was present in 30%, which is really dramatic. These patients were people who had POTS symptoms for a long time, so they may not have an autoimmune disease that hit them, let's say after Lyme disease or after Gardasil. And GI symptoms were common, and these were actually much more frequent than the Mayo Clinic, of course. So there's a study that was many times the number of patients, and you can see just the percentage of patients who had GI symptoms were dramatically increased. Now, there were actually slightly more in EDS patients versus non-EDS. Some interesting things about EDS: it affects the connective tissue everywhere, head to toe. And in the gut, it makes the mesentery kind of loopy, droopy, and the bowels sag. And so that's one way that the bacteria can be in a stagnant loop of small bowel, and that's how you can get bacterial overgrowth. And also there's deposition of proteins in the gut that can affect it. And then, as we'll see, mast cells play a role in EDS. So many patients have mast cells, which are really a very interesting cell, as we'll see. And patients with EDS have a lot of joint pain. And if you biopsy the skin near the joint, you'll find more mast cells there than people who have than controls. So what are mast cells? First of all, they're defenders. If there's injury or burn or infection, you'll have mast cells that are produced that help in a variety of ways. But we don't normally have mast cells circulating in the blood like we do neutrophils or monocytes or white blood cells of other types. They're produced in the marrow, and they come out in immature form, and then they migrate to places that are inflamed, and they help defend. But if they are abnormal, they have mutations, which is a phenomenon in mast cell activation syndrome, MCAS. They act poorly. They're bad actors. They release toxins. Now they're not malignant per se, like systemic mastocytosis, but they're yet condition. They're bad actors that form this condition of MCAS. And it may be triggered by T cell, lymphocyte activity, or abnormal microbiome, including fungus and abnormal shifts in the good bacteria. And these mast cells have many receptors, and so if you're allergic to fish and you have IgEs mediated by exposure to shellfish, then you can get anaphylaxis. This is one of the triggers, things that can trigger anaphylaxis. And then you can see also that there are spots for IgG and cytokines, which are inflammatory proteins. And it's common. Dr. Afrin estimates 1 to 17% of the population may have mast cell syndrome. 200 different proteins, enzymes, and factors come out of mast cells, and so you can be affected in so many different ways. With respect to GI, we see common things, reflux, dysphagia, gastritis. It makes histamine, which increases antacid output. We're going to go over some of these details. And also, when you look at, I'm going to digress for a second, when you look at the 45 different symptoms with mast cells and 50 different symptoms of POTS, there's an overlap, 17 symptoms overlap, because mast cell disease and POTS are concomitant. There's overlap syndromes, and there are also overlap syndromes and symptoms of EDS. So, when you're taking a history from a patient, you just have to realize, it's complex. These are complex symptoms and complex syndromes. So the top 50% in terms of frequency of mast cell disease, we have nausea and heartburn being very common. But if we just concentrate on GI symptoms, so Dr. Afrin, who was in University of Minnesota, is now in private practice in New York, looked at 413 patients, and these are all the GI symptoms that were present in his patients. Very common. So in terms of being a gastroenterologist, of course, that's all I think about, or thought about, and so there's some new things. So Dr. Quattromani may see patients with idiopathic chest pain, and so there's 2 case reports of seeing mast cells under the microscope and responding to mast cell therapy. Heartburn could be caused by excess histamine secretion and getting hyperacidity. So the stomach, there's also often indigestion, and could be due to the histamine, but also histamine acts as a chemical that increases pain fiber sensitivity. And it can secrete substance P, which is also a neuroreceptor. And then gastroparesis, slow gastric emptying, occurs in 1%. So here's pictures on the left of a control patient, biopsies of the lining of the intestine, and then on the right, tryptase markers on an IBS patient showing many more mast cells in the IBS patient, and the closer those mast cells were to the sensory nerves in the gut lining, the more severity they had of pain. There have been a number of studies, I'm not going to belabor this, that link mast cells to abdominal pain. And there have been a few studies looking at patients who have refractory irritable bowel syndrome, treating just for the mast cell and then getting them better. Constipation may be a factor. There's a small group of patients that have such severe colonic inertia or lazy colon that they go for colectomy, and their small intestine is hooked down to the rectum, and they often are very problematic, but some of those patients appear to be related to mast cell activity in the nerves that stimulate peristalsis. Mast cells even go to the liver, and so if you've got abnormal liver chemistries, your doctor takes your blood, you're a POTS patient, takes your blood, your cholesterol's high, your liver chemistries are elevated. Think about mast cell because it's very common. So why haven't the gastroenterologists been smarter? They have an IBS patient and they take biopsies to rule out microscopic colitis, which of course doesn't cause pain anyway, just pain is diarrhea. And the basic stain that we use doesn't show it. And so you have to get a stain for these mast cells, and then only with the CD117 stain do you actually see it. So you have to look. So I'm not going to comment much about the usual POTS symptoms, but it doesn't work well, because you're really not getting at the heart of the matter. The usual EDS treatment is listed here. It's important, but it may not get at the heart of the matter if you're not treating the mast cells that are causing pain. And we've been shown this slide, and here's the usual mast cell treatments. And additional treatments that may not have been touched on, but you can look here. There's some natural therapies that can be done, and dietary therapies that I think are very important. But I'm going to touch now on new ideas. So immune therapy for GI disorders in general, I'm going to touch on very briefly, because that's going to lead into how my patient who suffered for 25 years got better. So there's a Mayo Clinic study that took patients who they thought had a motility disturbance due to autoimmune phenomenon. They checked at blood tests, they gave them immune therapy, and people got better. And here's another study where these patients had paralyzed stomachs, gastroparesis. They treated with everything in the book. They even put a pacemaker in the stomach. Nothing worked. They treated them with immune therapy, and 2/3 of the patients got better. So applying immunotherapy to the nervous system is something of interest. Now, for years, actually, ganglionomic autonomic disease, which is a specific disease of hypotension, it's on one of the boxes that Dr. Quattromani showed of, her last slide, numerous autonomic disease, where they've shown immune therapy work. But this year, a paper came out showing one patient with POTS who got better with immune therapy. There are pockets in this country, New York, Pittsburgh, Mayo Clinic in Arizona, Scottsdale, where they're using IVG routinely for their POTS patients and finding good results. So we actually, and mainly Jill, who's the patient that I showed you, interviewed patients who posted their experiences with IVG in the POTS support group online, and 9 out of 13 improved. And it ranged from no results to miraculous. And so the words from our interviews are listed up here. Of course, it's not FDA approved for POTS. It is approved, however, for dependent pressure-induced urticaria. So think about that in case you haven't. Anybody who's ever seen me knows me to be a major fan and a prescriber of low-dose naltrexone. This is a short-acting opioid antagonist, so it's a narcotic blocker. It blocks the receptors for endorphins. It's short-acting, and so it hangs in there, and it tricks the body into making more endorphins. Endorphins reduce B and T cell activity, and it regulates cell growth. It reduces cytokine production. Cytokines are the inflammatory chemicals, and it reduces pain by a specific measure. And I think everybody with POTS or mast cell disease knows they have pain, lots of pain in these two syndromes, and with EDS too, possibly because of the mast cell. So endorphins, the good narcotics that our body makes, that runner's high is all about, activate the mu receptor, which relieves pain. That if you regulate the T cells, then there's less cytokine and less sensory pain, and also you can reduce the cytokines, which are one of those chemicals that activate the mast cell to secrete the mediators that cause so many problems in the body. So LDN also, naltrexone also directly reduces pain by binding to a toll receptor, which is on the white blood cell attached to nerves. So there's a inflammatory system and condition that can be directly affected by naltrexone. And I've treated a number of patients specifically with pain. I've treated many, many more patients, diseases with LDN, but the ones in yellow I'll highlight as just quickly go over, and then I'll go over what happened to that patient. So Ehlers-Danlos, here's a patient who has chronic leg pain, which I'm going to talk about in a minute. These are various explanations for why people with EDS get pain. CRPS, that's a complex regional pain syndrome, a very devastating problem, which some people with POTS and mast cell have. And so this woman found out she had celiac disease, went on a gluten-free diet. Her skin disease, dermatitis or pediformis, didn't get better. She saw me, and because she had EDS, joint pain, and an autoimmune disease, I treated her with LDN. Her rash went away. 2 years of rash went away within 2 months, actually, and completely away in 3 months. And then she's been treated for 2 years with LDN and a marked reduction in her joint pain. CRPS, I reported a patient who had obstructive sleep apnea, irritable bowel syndrome due to small intestinal bacterial overgrowth. She suffered for 8 years with pain, migrating from one part of her body to another. She had pseudomotor, which is a neuropathic phenomenon involving the veins, and causing edema and redness of her legs. And you see before and after treatment with LDN and treatment with a better mask for her sleep apnea problem, and SIBO therapy with the antibiotic, she was cured, and I just saw her for a standard colonoscopy. In 2 years, she's been in complete remission and doing very well. So, my patient from Alaska, well, she moved from California to Alaska because of the heat. She would pass out, and she was mugged when she passed out once in California. So she moved to Alaska, where she could keep the house temperature of 65. And she actually is a statistician, a biostatistician, and a researcher, and she's on the committee Stand Up to POTS. So she dug around in literature and found that LDN helps pain, and she had diffuse body pain, severe pain with lying down. She couldn't get any sleep. And she also researched IVIG and got that approved because of dependent urticaria. on her own. And then she called me because of continued GI symptoms and